So this morning I thought we'd talk a little bit about obesity and its risks and its treatments. So we'll try and talk about obesity as a chronic disease and not just bad habits. And hopefully I can convince you that it is a chronic disease and give you some evidence for that. Talk a little bit about the risks of being obese and mention that all fat isn't the same, and the importance of insulin resistance in relationship to the different kinds of fat. And then what are the treatments available? Because we have some new ones now. And we'll talk about diets, food, dietary supplements, medical foods, exercise, drugs, and devices, and surgery. So obesity is defined as an excess of body fat, and it's not easy to measure body fat inexpensively. And so a ratio of the weight over the height in squared is a way of estimating body fat for people who have normal lifestyles. It doesn't work very well for people who are bodybuilders and have lots and lots of muscle, but for the average person it does. And so that's the way we define obesity. And it's divided into categories. Up to 25 is normal, 25 to 30 is overweight, and above 30 is considered obese. Whoops. Okay. Well, the NHANES stands for the National Health and Examination Survey, Nutrition Examination Survey. And it's something that our federal government does. And it's a representative sample of the population of the United States. And so what you can see here as the prevalence of obesity in 1960 was about 10% in men and about 15% in women. And between 1960 and 1980, it was relatively flat. It went up a little bit, but not a great deal. And then in 1980, you can see what started to happen. It's starting to level off in women, but it's continuing to go up in men. And so since that time, the prevalence has more than tripled. So what causes obesity? Is it our genes? Well, genetic causes do exist. And there are people that don't have any leptin, which is a hormone that comes from fat tissue. And those people become very obese, and when their leptin is returned to them, then they become lean again. And this is important not because it's very prevalent, but it's important because it convinced people that obesity could be a hormone problem. But we know our genes didn't change in the last 30 years. That doesn't happen that quickly. And so there must be things in our environment that are playing a role in this. But just to go back to the genetic aspects, there's only 3 people that are adults that we know of that have leptin deficiency. And they were born in Turkey in a family that intermarried. And these are the 3 people. And I'm going to try and illustrate as much as I can the things that we've learned through things we've done here at Pennington. And so these people are at a little recreational time off of their study at the Alligator Bayou, when they used to have a little place out there for people to buy drinks and food. And they were started on leptin here at Pennington, and they lost about 50 pounds for about 12 weeks. And this is their pictures when they appeared on Good Morning America. They lost about half their body weight. And you can see he's no longer obese because he has his leptin back. But there is a physiology around obesity for all of the people who have it. And so just like some people have blood pressure that's controlled higher than is healthy, there are people whose bodies try and control their weight at a level that's higher than is healthy for them. And so this is a study that was done with the drug we no longer have, but they were in a practice environment. They came into this medical practice, and they were obese, and so they were started on this medication for obesity. And over the course of 6 months, they lost weight, and then during the next 6 months, they maintained that weight loss while they were taking the medication. Just like with blood pressure medicine. Your blood pressure doesn't go down to 0, it just goes down a certain amount, and then it levels off. Well, then they were taken off the medication, and you can see what happened. Over the next year, their weight basically came back to where it was. So this is something that's physiologically controlled. Well, we said that the prevalence of obesity has been increasing. Is that important? Well, yes, it is important. It's important, especially in women. Obesity is stigmatized, and it causes a lot of psychological distress for many people. But in addition, it causes medical problems. It increases your risk of developing diabetes, high blood pressure, heart disease, cancer, and arthritis, which can lead to disability. So it is important. It also increases the risk of death. So here you see that if you say that the person has a risk of 1 of dying when they're at a normal weight, when they get to be obese, they have a 50% greater risk. And this just addresses the disability aspect. This is a group of women who were classified as being obese but with the Metropolitan Life Tables, and they were divided into the lowest fifth and the highest fifth of weight. And the people who were at the highest fifth had 5 times as much arthritis as the people who were at a normal weight. But probably diabetes is the most important risk factor for being obese. Here you can see that compared to a normal weight individual at less than 22, when you get to 35, you've got 100 times the greater risk of developing diabetes as you do when you're lean. And I think I mentioned that before, that the prevalence of diabetes follows by about 10 years the prevalence of obesity. So we said, well, obesity started to go up in 1980. Here the prevalence of diabetes is still fairly flat, but around 1990 it started to do this. And diabetes has tripled since the 1980s and is continuing to increase, as you saw in that graph. It's now about 8.2% of the U.S. population has type 2 diabetes, and it's thought that it'll be over 10% by 2020. And only about 0.2% of those diabetics have type 1 diabetes. That's the kind of diabetes that children get and have to remain on insulin the rest of their lives in order to treat. So most of it's the type that occurs in adults who have weight issues. And over a quarter, whoops, sorry about that. More than a quarter of the U.S. population has what's called prediabetes. That means their blood sugar is higher than is truly normal, but it isn't in the diabetes range yet. But those people are at greater risk for diabetes than people who have a normal blood sugar. And diabetes is extremely expensive. It's been estimated that there was $194 billion spent on diabetes care in 2010, and that it may reach $500 billion in 2020. And that there'll be $3.4 trillion spent in diabetes care over the next decade. And the expenses of diabetes and obesity-related diseases like cancer, heart disease, and others are going to stress our healthcare budgets. They already are, but it's going to get worse. Well, not all fat is the same, as I mentioned earlier, and if you take this person's body and you sort of do a cross-section here with a CAT scan, you get something that looks like this. And the white is organs and muscle. And so this dark gray area is fat. And so this is called subcutaneous fat because it's under the skin. The fat inside that black line like this and this, is called intra-abdominal fat or visceral fat. And that's the fat that carries a greater risk of insulin resistance. And insulin resistance is what's associated with high blood pressure, diabetes, and blood fat abnormalities. So something that I thought was sort of interesting, if you talk about insulin resistance, apple-shaped people, which men are apple-shaped people, they tend to have higher amounts of visceral or abdominal fat. Women can be apple-shaped as well, but they also can be pear-shaped. And being pear-shaped is not so much of a medical issue. So people who are insulin resistant have high insulin levels, like over 15. That means it takes more insulin for them to keep their blood sugar at a normal level. If you're insulin sensitive, it means that you can keep your blood sugar at a normal level with low insulin levels. So most of the people who have weight problems are insulin resistant, but there's about 20% who are insulin sensitive. And so what one study did is they took two groups of obese people. One group was insulin sensitive with insulins less than 10. The other group was insulin resistant. And for both groups, they divided them into two and gave one half a high-fat diet with 40% fat, and the other group a high-carbohydrate diet with 60% carbohydrate. And they did this for 16 weeks. And what happened is that those people who were insulin sensitive lost twice as much weight on a high-carbohydrate diet. But those people who were insulin resistant lost more weight on a low-carbohydrate diet. So it may be that when people say, well, this is the best diet or that's the best diet, and try and make these generalizations across the entire population, this may not be entirely fair. One may be great for some people, but it may not be the best for another person. And this just shows that the improvement in insulin sensitivity, the drop in insulin, in other words, was greatest on the diet that people lost the most weight on. And if you looked at a low-carbohydrate diet across an entire population, you didn't get much different. But if you looked at the people who were insulin resistant, they lost more weight. So this is just another example of the same thing done in a different way. Well, we talked a little bit about diets now. I thought I'd mention dietary supplements. And one of the things that we've done here at Pennington was to look at a plant called Qsymia as a treatment for high blood pressure, which is, of course, associated with obesity. And Qsymia is a tree, and one of the scientists from LSU brought it here from China, and it's growing on the agricultural farms at LSU. And so the bark, which is used as a tea in many other countries, was made into sort of an extract in pill form. And we took 30 healthy people who had blood pressure above what was ideal, which is 120/80, but not so high that it would be dangerous to do it. And then we gave them 2 of these pills 3 times a day, or a placebo, for 2 weeks, and we had them wear this monitor, which was sort of like a blood pressure cuff with a little pack that they carried around that took their blood pressure automatically every hour for 24 hours. And what we found was that there was a drop of blood pressure of 7.5 on the top and 4 points on the bottom. And then in the laboratory, we were able to show that one of the ways that it works is that it's a beta blocker. And what that is that there are medications that are given by prescriptions that are beta blockers, and they're used to treat certain heart problems and high blood pressure. So this is sort of a natural one. And this is just a picture that shows that on the top you have the placebo, and this is the top number on the blood pressure. And I think you can see that that top line is higher than the bottom line. Obviously, blood pressure varies throughout the day, but on average, the blood pressure is lower on the bottom also than it is on the top with the squares. And in this picture, you have the pulse rate. As I mentioned, beta blockers decrease your pulse rate. And so here you have lower pulse rates than you do up here. So the next type of treatment is called medical foods. And to illustrate that, I thought I'd show you some studies we did with grapefruit. You know, grapefruit's been a sort of a traditional diet food. And so we had a grant from the Grapefruit Growers Association in Florida, and we compared grapefruit capsules, which were made from the grapefruit, a glass of grapefruit juice 3 times a day, or a half a grapefruit 3 times a day. And what we found is that the grapefruit really did help people to lose weight, but that's not very much weight loss. It's about 4 pounds over 12 weeks. But the interesting part was that those people who were insulin resistant, also that's called the metabolic syndrome, because it is insulin resistance is associated with high blood pressure, diabetes, and high fats in the blood, that those people who had that problem actually were gaining weight on the placebo, but they all lost weight on the grapefruit things. And the amount of weight loss was much more. So that and then we did what's called a glucose tolerance test. You drink a sugary drink, and then 2 hours later you check and see what the insulin and blood sugar is. Well, the insulin levels dropped when they were on the grapefruit, but they went up on the placebo, and that's because the placebo gained weight, and so you would expect that. And then what we found is that this chemical, naringenin, is the active ingredient in grapefruit that does this. And there's an enzyme in fat tissue that converts cortisone, which is inactive, to cortisol, which is active. And this inhibits that enzyme. And that's what makes the belly fat. And so this can be developed as a medical food because this comes from a food, is presumed to be safe, and so you don't have to go through all the safety trials that you need to go through for a drug, but yet it's still supposed to be prescribed and supervised by a physician, unlike supplements, which you can just go to your drugstore and get. Well, let's talk briefly about exercise, because I think there's a misconception that exercise is a great way to lose weight. It's not. And let me show you. The red line was diet alone. The yellow line was diet plus exercise. The exercise people lost a little bit more, but not an awful lot more. But the important part about the exercise is that from here to here, this was 8 months, this is another 10 months, they maintained that weight loss if they continued their exercise. These people here started on exercise, were only on diet, they maintained the weight too. But if they stopped the diet and they didn't start the exercise, this is what happened. So sometimes it's even easier to lose weight, as hard as that is, than it is to maintain the weight loss that you achieve. And that's where exercise is extremely important. So I don't want to say this to minimize exercise, but the exercise is really important to maintain any weight loss you get, and that's usually done with diet. Well, let's talk about drugs, because there's some new drugs that have just been approved, and I thought you might be interested to hear about. Liraglutide is also called Victoza. It's a drug that is given by a shot, and it's used to treat diabetes. And at higher doses, this is higher than the dose used to treat diabetes, is about double that. It causes weight loss of about 8.5% of a person's body weight over the course of 20 weeks. Orlistat is the only drug that's presently approved for the long-term treatment of obesity. And orlistat gives about a 5.5% weight loss. Now, Lorcaserin is the generic name of a drug that was just approved in about the last month and should be hitting the shelves probably later this fall. And it's going to be called Belviq. And this shows that this drug, Lorcaserin, causes about a 6% weight loss. Well, you probably remember fen-phen. It was a very popular weight loss combination. It's a combination of phentermine and fenfluramine. And it caused about a 15% weight loss, which was like double what a single drug usually causes. And people were really thrilled about this, and it became very popular, but unfortunately, fenfluramine caused heart valve problems, and it was taken off the market. Well, what this Lorcaserin is another fenfluramine that doesn't cause heart valve problems. So although it's a new drug and it's never been tested in combination, my presumption is that one of the first things that's going to happen when it hits the market is to try it out with phentermine. And if it's as effective with Belviq or Lorcaserin as it was with phentermine, we may have another combination that gives a 15% weight loss. Now, there's a second medication that was just approved and will also be available for sale in the drugstores by prescription later this year. And it's called Qsymia, and it's a combination of two drugs, phentermine in a lower dose and topiramate. Now, topiramate is a drug that's been approved to treat epilepsy, and it's been approved to help people who have migraine headaches from getting them. And it's going to be sold in two doses. The low dose gives about a 7% weight loss, and the high dose gives about a 15% weight loss. So another combination giving about a 15% weight loss. Now, Contrave is another combination drug, and the advisory committee to the FDA suggested that this should be approved. The FDA said, well, it causes a little bit of an increase in blood pressure, 1 or 2 points, causes a little bit of an increase in pulse rate. We want you to do a safety study first to prove that it doesn't cause any heart attacks or strokes. So that study's in progress, but it causes about an 8% weight loss. And if the study goes well, this may be available like in the beginning of 2014. This is a combination of bupropion, which is a drug that has been used to treat depression, and it's also been used to help people to stop smoking. And naltrexone, which is a drug that's approved and to help people that have alcohol problems to try and keep away from alcohol and who have addictions to pain medications. So this drug, we think, is going to be particularly helpful for people who have cravings, like chocolate or pizzas or whatever that might be for an individual person. Another drug that is a little bit further away, it's past 2 stages of the 3-stage process for drug approval, is one called Impadic. And it's the bupropion, this time combined with zonisamide, which is an epilepsy drug. And in this, the top dose also gives a 15% weight loss. So whereas right now we have something that causes about a 5.5% weight loss, it looks like we're getting better drugs, well, more effective drugs at least. Now, as drugs are developed for chronic diseases, they usually start with drugs that work on the brain. So this was seen in high blood pressure drugs, for example, and phentermine is an example of that for obesity. The next thing that happens is that these drugs tend to be combined at lower doses in order to get better effects but with lower side effects. And that's basically where we are now. I've just told you about the combination drugs that are being developed for obesity. But the next step is to try and get drugs that work right where they're needed. Like for blood pressure, there's some drugs called angiotensin receptor blockers. Now, those drugs work on the blood vessel. And so there really is very few side effects because it's working right where it's supposed to work. And so now, earlier in this development process, there are some drugs for obesity that work outside the brain on the metabolism. And one of them is called beloranib. And this is a study that was done with mice. If you put mice on a high-fat diet, they gain weight compared to their normal diet, which is mice chow. It's very, very low fat. If you take these mice that are on the high-fat diet and put them on beloranib as well, this is what happens. It comes down to normal or below. And there's been one trial in humans. It's a 4-week trial, and the women in this trial lost 1% of their body weight every week for 4 weeks. And it was still going down when the trial had to end. So this is early development, but it was seen to be well tolerated, and it's promising for having better drugs in the future. Now, we talked a lot about, I talked a lot about drugs, but I do want to emphasize that drugs work better when they're used in combination. Okay? So here's a drug called sibutramine. It's no longer available to us, but it caused about a 5% weight loss. If you added behavior modification, which is diet, exercise to that, which is something that you could do by going to Weight Watchers, you double that weight loss. But if you then add what are called calorie-controlled portions, or like they might sell at Jenny Craig along with the behavior modification program, then you get about 3 times the weight loss. So drugs sometimes are needed because diet and exercise may not be enough for everyone, but that doesn't mean that they should be abandoned. They're important too. Now, I'll touch briefly on surgery and devices, and then we can open this to questions. There are 2 common operations that are used to treat obesity. One is called the gastric bypass, or the stomach bypass. And this is a picture of what's done, but basically what happens is that the food doesn't come into the intestinal tract until 20% of the upper intestinal tract has been bypassed. And this can result in some decreases in the ability to absorb iron and calcium and things of this nature. The sleeve gastrectomy is a newer operation, and it basically takes the bag part of the stomach off, so the stomach's nothing but a tube. And it seems to be about as effective in both reversing diabetes and in causing weight loss as the bypass. But it only has about 5-year data instead of 16-year data. The band is a device. What it is, it's a sort of a plastic collar that goes around the top of the stomach where the food tube meets the stomach, and it's adjustable so that you can make it tighter or looser. This shows the weight loss with the gastric bypass. And people lose about 35% of their body weight, or a third of their weight, and that occurs over about a 1.5 to 2 year period. Then there's a little bit of a weight gain, maybe to about 30% weight loss, and then that's maintained over the rest of the 16 years. As I mentioned, the sleeve gastrectomy is close to this, but we only have about 5-year data so far. This shows that there's about a 30% weight loss with this stomach bypass. This shows there's about a 20% weight loss with this band. And recently, in the last year or so, the lap band, which is this device, was approved for people with a body mass index of 30 or above, as long as they have some sort of problem that's going to get better if they lose weight. So obesity is prevalent, and worldwide it's getting worse, and it's expensive to our healthcare system. I hope I've convinced you that it's a chronic disease that has physiology involved and not just bad habits. And chronic diseases require chronic treatments, whether it's exercise to maintain your weight loss for the duration, or taking medicines on a chronic basis like you would for blood pressure. And sometimes lifestyle, like diet and exercise, isn't enough for some people. And so there are treatments other than that: diet, supplements, medical foods, drugs, devices, and surgery, which I tried to give you examples of based upon some of the things that we've done here at Pennington. And as drugs for obesity are developed, I usually start with ones that act on the brain, then go to combinations with lower doses that increase effectiveness and lower side effects, and then finally to drugs that work outside the brain, like we've now finally come to with high blood pressure. So I'll be happy to try and answer any questions.